Assalamu alaikum. Today, we are not just talking about how to hold a forceps or a grasper. We are talking about the cognition and physical shift which is required for laparoscopic mastery. The transition from open surgery to laparoscopy is a transition from a 3D tactile world to a 2D visual screen. Our goal today is to bridge that gap by focusing on 4 pillars: the ergonomics, the physics, that is the fulcrum effect, and the triangulation and the safety. And by the end of this session, you should be able to approach the monitor not just as a viewer, but as an integrated part of a surgical system. So here we begin the presentation on mastering the fundamentals for surgical precision in laparoscopic surgery. So as we mentioned, this is a paradigm shift from 3D tactile feedback to 2D visual feedback, and these are the principles. And the principles are the ergonomics, the physics, which is the fulcrum effect, and the hand-eye coordination and triangulation, and the principles of safe energy application. So talking about the ergonomics, it is often overlooked until a surgeon develops a chronic back or neck pain. So to perform at your best, you must be comfortable. The monitor should be at the level of the eyes or just below it. If you are looking up or to the side, you are straining your cervical spine, and the monitor should be directly in your line of sight, slightly below your eye level. The table height, it should be. This is the most common mistake. In open surgery, the table is high, but in laparoscopy, the handles of your instruments, they add 20 to 30 centimeter of height lower than the table until your elbows are at a relaxed 90 degree or to 120 degree at an angle. If you can't lower the table enough, stand on a step tool. Your shoulders should never be shrugged during a case. So the golden rules for the ergonomics are, and these are to reduce the musculoskeletal fatigue to maintain precision during long procedures. And the golden rules are the hanging elbow. It is that to adjust the table and to avoid any shrugging of the shoulders. If there is shrugging of the shoulders, it means the table is too high. So you have to bring down the table, or you have to lift yourself up. And the second principle is the line of sight. The monitor should be directly in front of you, or it should be a little lower in order to prevent the cervical strain. And that is the stance, and you should that's the first point here, is the surgeon stance, is that you should be standing in a boxer's stance with feet and shoulder width apart to allow weight shifting during the long procedures. Okay, then is the port placement and triangulation. As we all know from my old presentations, that there are many ways to place your ports. The topmost, which is the most famous one, is the baseball diamond concept. In this case, think of your port placement like setting up a camera for a movie. If the ports are too close together, you will be swording and you will be doing a sword fighting all day. So the target organ in a baseball diamond concept is that the target organ is the home plate, where the batsman is actually standing, and the camera port is the pitcher's mound, where the pitcher is actually standing, and the second and the third base are actually, the first and third base, sorry, are actually the working ports. So your camera is the pitcher and your target is the home plate. If you place your bases, that is working post, too far forward or too far backward, you lose your leverage actually. And this is, you must always map out your ports on the skin before making the first incision, keeping the patient's body habitus in mind, small body habitus and large habitus. There is a 10 centimeter rule. Keep the ports roughly 8 to 10 centimeter apart. As I always mention in my triangular technique, that the distance between the two ports should be a full hand. It is actually 10 centimeter depending on the size of the surgeon's hands. And the picture to home plate is always align your camera to the picture directly behind the working instrument, targeting the pathology. It should be right in front. However, the working angles are the azimuth angle is actually the angle between the camera and the one working port. This is called the azimuth, and the manipulation angle is between the two working ports. So this angle must be kept 60 degree for the optimal performance. If the angle is too small, there will be swarding, and if the angle is too large, you will not be able to perform your basic steps, like for example the dissection, like application of the clip, like suturing. So the sword fighting is avoided by placing the ports. So triangulation is usually followed in this. Then is mastering the fulcrum effect. What is fulcrum effect? It is basically the physics. You can see that the abdominal wall is actually the central or the pivotal point, where half of the instrument is inside and half of it is outside. So it is performing, it is acting as a perfect circle point, where you can take it as a pivotal point, and the instrument, if it is completing a 360 degree movement, it is making a perfect circle. But if the fulcrum point is not at the center of the instrument, then of course the path or this perfect circle cannot be made. So the fulcrum effect is the biggest hurdle for beginners, because when they place the port in not a proper position, the fulcrum effect is actually lost, and they make a type 1 or type 3 lever, which leads to effect in such a way that they are not able to perform properly. And the other thing is about the fulcrum is actually that when you are moving your instrument, like for example, if you are moving your tip of the instrument towards the left side, actually you will be moving the handle towards the right side, and this leads to paradoxical movements, and majority of the surgeons during the initial part of their laparoscopy are not able to understand that, and gradually with achieving the learning curve, they actually start their hand-eye coordination. So the fulcrum effect is the biggest, because the abdominal wall is a fixed pivot point, and every move you make is actually inverted. For the urologists, this fulcrum effect is usually not as important as compared to the gynecologists or the general surgeons. And the reason is that the urologists, right from the beginning, right from the start of their training, they are doing endoscopic procedure, and this fulcrum effect is present there. So their mind and their hand and eye and brain coordination is already developed. So they take shorter amount of time to adjust to the laparoscopy as compared to the general surgeon and the gynecologist. And the important thing is that there is tactile loss. So you will lose about 40% of your tactile feedback compared to an open surgery, and you have to learn to see the tension in the tissue. So in order to achieve this art of depth perception, you have to use the monocular cues, and these monocular cues are as below. So you have to use the shadows. The light on the telescope is in such a position that it is on the upper part of the telescope, so that it is throwing light like this, and you can see the shadow of the tissue and the shadow of your instrument. So you have to use those shadows and light source to gauge the distance and judge the depth of the tissue. Then is tissue deformation. You should watch how the tissue is moving when you are touching it, and this can also give you a perception of depth. Then of depth, sorry. And then is the remote center for motion. It is to minimize the trauma at the entry site. Then talking about the dimples or monocular cues, that how the tissue is deforming while you are touching it, the way the tissue dimples, and to understand the depth and pressure. This is called actually the visual haptics. Since you lose 3D depth, the monocular cues, they are helping you. You should watch for blanching of the tissue indicating high tension, and dimpling indicating contact. So when there is dimpling, it means that you have contacted the tissue, and if there is blanching of the tissue, it means you are using an excessive force there. And then is the traction symmetry. You should use your non-dominant hand, because your non-dominant hand is actually your friend, which can provide constant counter traction for you, successfully dissecting the tissue that you want to create a plane of light and a thin translucent layer of connective tissue. And then is the gentle grasp. You should use the smallest amount of force necessary. If the grasper is clicking to the last ratchet, you may be causing occult crush injuries. So do not use excessive forces. How to use atraumatic tissue handling is that in laparoscopy, the non-dominant hand. So the plane of light is created by pulling the tissue in opposite direction by your non-dominant hand. And this leads to a translucent plane, which is easy to dissect. And the grasper choice is that be mindful of the footprint of your instrument. You should know which instrument are using and where you are using it. A fenestrated grasper distributes pressure evenly over a large area, making it safer for the bowel and of course the vessels. And conversely, using a heavy grasper on delicate tissue is a recipe for an occult injury that you may not see until 48 hours post-operatively, because that area is actually crushed, and that crushing may not lead to appearance at that time, at the time of surgery, and later on when the pressure increases after the patient's pneumoperitoneum is released and the patient is recovering and the BP is high, the pulse is high at that time, and this may lead to injury of the or rupture of the vessel, or after 48 to 72 hours when the gut actually perforates. Okay, now coming to the essentials of electrosurgery. The energy devices are incredibly powerful, but they carry hidden risks. So you must be aware of the lateral thermal injury. In monopolar, whether scissors or hook or any other monopolar instrument, there is a high risk of lateral thermal injury. And you should always visualize the tip of that instrument while using the diathermy, so that you should know what structure or what tissue is it touching while you are using it. Okay, so just because the tissue looks fine doesn't mean it isn't cooked 5 millimeters away. So there's a depth which is called the lateral thermal spread. This is critical near the ureter or the bile duct, or a vein or an artery, or or any part of the viscera that you don't want to destroy. Then is the capacitative coupling in the monopolar. This is a ghost current that can jump from your instrument to a metal cannula and burn the bowel outside your field of view. This is called capacitative coupling. So the current has actually jumped to your port, and that port is actually touching the gut, so this can lead to injury. That's why monopolar sources need to be under thorough scrutiny before using it. You should check for any micro punctures in the insulating sheet. Then is the safety tip: always keep the active tip of your hook or scissor in the center of your screen. If you can't see it, don't fire it. Then a little bit of summary of all these points is that the thermal spreads, remember the lateral heat can travel up to 5 to 10 millimeters beyond the visible tip. So be exceptionally cautious near the ureter, the bile duct, or the nerves, or the structures that are not meant to be destroyed. Then the hover rule: you never move your active electrode out of the camera's field of view while it is still in use or still hot, and you should wait for the here you can see the concepts that you should avoid the hybrid trocar system, that is plastic and metal, and you should also look at the insulation failures, check the instruments regularly, the insulation sheath. If it is punctured or broken, you need to replace them before using it. And then is the cool down rule: you should wait for at least 2 to 3 seconds after activating an ultrasonic scaler before touching a vital structure, because it is still hot. And while using a monopolar diathermy, you must use it for only 3 seconds, and count it: 1, 2, 3, and then stop. Then start buzzing: 1, 2, 3, and then stop. And then for 2 to 3 seconds, you should not touch any viscera with the same instrument, whether a hook or a scissor or a Maryland forceps. Bipolar is safer for hemostasis, and that is because the current stays between the jaws. So, okay, how to okay, coming to the basics of suturing and the knot tying. The suturing is the black belt skill of laparoscopy. There is no future without suture. So the first thing is to grab the needle. The needle should ideally be grabbed at a 90 degree. So if your needle isn't loaded perpendicular to the driver, you will struggle with every pass. Then is the C loop. While knotting, you should use a C loop, a C and then an inverted C. And the instrument with which you are knotting should be in the center of that C loop, and then you take 2 loops, and then you grab the tail, and then you proceed with your knotting. You should not chase the thread. Lay the thread down in a C shape on the tissue and then reach through the C to grab the tail. And economy of motion is that the goal is to move your hands as little as possible. Use the move the ground technique and move the tissue onto the needle, rather than trying to wrist the needle through the tissue in order to be safe. So keep the suture short, 15 to 20 centimeters, just to avoid any tangles, because if the suture is too long, you will be in trouble. And if it is too short, then you will apply 1 or 2 knots, and then the suture will become short for you to throw any other knots. So keep it between 15 to 20 centimeter, and always use the follow-through technique to prevent tissue tearing. And the surgeons not always throw 2 times 2 knots in the first loop to maintain tension in the slippery environments, so that the knot does not loosen up while you are taking the 3rd knot. Okay, then the error management, how to if you have made an error, how to manage it, and what is the safety, because this is a red line. So the first thing is that loss of vision. If there is loss of vision because of splash of blood, if there's a loss of vision because you have touched the tissue and then you cannot see, or if there is excessive smoke because of the use of cautery, is that you should use shorter bursts of energy so that there is less amount of smoke form, because if you use longer, then of course there will be more smoke that can lead to blurring of the lens. So if the view is obscured, pause, take a pause, stop, and then you can bring the lens into the port, maybe more than 50 centimeter into the port. That can lead to defogging, or you should just take out the camera and clear the lens with either cleaning, or you should use an anti-fog solution, which is a bit expensive. Okay, then there is a 20 for a conversion. You should know when to convert to open, because it is a sign of expert judgment and it is the height of expertise of a surgeon. It is not a failure, and you must know a 20 minutes rule. If you just drag it, just make it a 30 minutes rule. That is, if you have made no progress on a specific step for 20 to 30 minutes, you should just stop, change your angle, add another port, or call for a senior to consult, or if not, you should just convert the procedure to open. Then is the hurdle. The hurdle is just communication with your team, your scrub nurse or the scrub technician, and also with the anesthesia during complications. So if there is bleeding, do not panic. Apply a direct pressure with a grasper or a sponge first. The grasper should be a non-traumatic one, and then you should not use the diathermy blindly. And after taking temporary control, you should look for the source, the site of the bleed, and then see if you can manage it laparoscopically by finding the point distal and proximal to the bleed. So see that if you can take control of that. If not, you should clamp it with one hand, keep the clamp there, and you should convert the procedure to open. So the conclusion and path to mastery is that you should do a deliberate practice and practice on the box. This is for the box trainers are for the muscle memory, and the operating room is for strategy. So practice, practice, and practice. You should review the recording and critiquing your own procedures, because this is economy of motion. You must not go through the same experience again and again. You should review your video, and the next procedure you should avoid things which you should have not performed. And the final thought, last but not the least, is a famous quote that slow is smooth and smooth is always fast. This leads to efficiency in laparoscopy, and efficiency in laparoscopy comes from reducing the unnecessary movements, not from moving your hands fast. So always keep this in mind. Slow is smooth and smooth is always fast. I hope this lecture or presentation has enlightened you and has given you a comprehensive overview of how to shift yourself from a 3D tactile field to a two-dimensional visual field. So these are the points that you need to follow. And thank you very much for watching it. Please subscribe and forward this channel for more.